Let's turn our attention to other medications under investigation for primary biliary cholangitis. These medications act by mechanisms different from ursodiol and obeticholic acid. The PPAR-alpha, or peroxisome proliferator-activated receptor alpha activity, is responsible for regulating bile acid synthesis, and it modulates phospholipid secretion, which helps protect the bile ductular epithelium. Fibroblast growth factor 19 is an endocrine hormone that helps regulate bile acids in addition to carbohydrate, lipid, and energy metabolism. It has a role in regulating hepatic cell proliferation, but the FGF19, FGFR4 signaling is also associated with hepatocellular tumorigenesis. Thus, an engineered FGF19 variant has been shown to be capable of targeting the bile acid homeostasis functioning, but not the proliferative function. Here are a list of drugs in phase 2 and 3 testing for PBC. In the PPAR-alpha class, we have the Fibrates, both bezafibrate and fenofibrate, and in the novel FGF19 analog, the NGM282 drug is under investigation in phase 2 trials. Dr. Kowdley, please discuss some of these investigational agents beginning with the fibrates.
So there's a study that's examined bezafibrate with ursodeoxycholic acid and examined the long-term outcome in urso non-responders with dyslipidemia. 27 patients were enrolled in a prospective randomized controlled multicenter study. Patients received continued administration of urso versus bezafibrate add-on to urso after more than 24 weeks with long-term therapy. Primary endpoints were alkaline phosphatase levels, Mayo risk score, total bilirubin, AST albumin, overall survival, cancer incidence, and safety with creatinine as an endpoint. Mayo risk score significantly was lower in patients who received bezafibrate and urso. However, mortality rate and incidence of HCC were not significantly different between the two groups. Interestingly, creatinine levels at 8 years were significantly higher in the combination therapy group. Although they were still close to normal, there was a significant difference, 0.94 versus 0.56. And it was called out that we should pay close attention to adverse events during the long-term combination therapy, and bezafibrate is not available in the US, but these data bear watching. Fenofibrate has been studied in a phase 2 study in patients with PBC and an incomplete response to ursodeoxycholic acid. Shown here is an open label study of 20 patients. Alkaline phosphatase levels did decrease significantly with a rebound after discontinuation. But once again, the use of fenofibrate is limited by a labeled contraindication for patients with hepatic or severe renal dysfunction, including PBC. But clearly additional data with the safety and efficacy of fibrates in treatment with PBC is warranted and needed.
Again, NGM282 is an engineered variant of FGF19 and has been studied in PBC in a double-blind placebo-controlled trial. And these data suggest that NGM282 is a potent regulator of bile acid synthesis and effectively reduces alkaline phosphatase levels when given to patients with PBC. Budesonide has also been studied together with ursodiol in treatment of PBC. Budesonide is a non-halogenated glucocorticoid absorbed in the small bowel with 90% hepatic first-pass metabolism. And there have been 3 studies that have looked at budesonide therapy in combination with ursodiol. 2 were randomized studies using 3 milligrams and 6 milligrams of budesonide respectively. And the 3rd was a non-randomized study using budesonide at a dose of 9 milligrams for 1 year. Cirrhotic patients were excluded as there's altered metabolism of budesonide in cirrhotic patients, and there's actually an increased risk for the development of a portal vein thrombosis. Both the randomized studies showed a greater reduction in serum alkaline phosphatase and improved the histology, both grade and stage, in those treated with both budesonide and ursodiol. And actually, the ursodiol group, the ursodiol alone group, had a histologic deterioration. In the non-randomized pilot study, there was only a very modest effect with budesonide. Thus, the use of budesonide is best reserved for patients with overlap syndrome with autoimmune hepatitis.